All right, today we're tackling one of the biggest and, let's be honest, most challenging shifts in our specialty, non-operating room anesthesia. You know it as NORA. We're stepping outside the familiar comfort of the operating room, and it's a whole new ballgame out there. Look, if you've mastered the controlled chaos of the OR, you're in the right place, because all those skills we've perfected are now in demand all over the hospital, in places that are, well, a lot less predictable. So let's really dig into what this means for us, for our practice, and for our patients. So here's our game plan. We'll start by mapping out the new NORA landscape. Then we'll get into the weeds on the unique challenges we're facing. After that, we'll do a deep dive into some really high-stakes areas like imaging, endoscopy, neuro, and cardiac cases. And finally, we'll look ahead at where our role is going. Okay, first up, let's get the lay of the land. It is so important to understand that NORA isn't just taking our OR skills on the road. It's a fundamentally different world, and it requires a completely new playbook. So what are we really talking about when we say NORA? You know, historically, this was the occasional minor case, pretty stable patients, and often we weren't even involved. But wow, has that changed. In the last couple of decades, this field has absolutely exploded. NORA now touches every single medical specialty, and it's a huge expansion of our practice. The procedures themselves are often just as complex and demanding as anything we see in the main OR. And just look at the speed of this thing. These numbers are incredible. In just 4 years, the proportion of NORA cases jumped from about a quarter to over a third of all anesthetics. This is not a slow creep. It's a rocket ship. And what's fueling it? It's new, less invasive technology and, critically, an older, sicker patient population that just a few years ago we would have said was too high risk for anything. This really gets to the heart of the matter. We are moving from our home turf, the OR, a predictable, standardized world that we built and control, to a perpetual away game. Every NORA case is in a variable, remote location, often with a team that doesn't speak our language, that doesn't know our playbook. It's a massive shift in context. Yeah, it really is a perfect storm driving this whole thing. You've got amazing new tech that lets proceduralists do incredible things. That opens the door for patients we never would have touched before. Sicker, older, often ASA class 3, 4, even 5. And now we're the ones responsible for getting them safely through these complex procedures in rooms that were never, ever designed for this level of acuity. And this is why we have to be so vigilant. The ASA closed claims database tells a pretty sobering story. Claims related to a patient death are almost twice as likely in these remote NORA locations as they are in the OR. And the number one cause? Respiratory events. This isn't just a number on a chart, it's a red flag. It tells us we have to fundamentally rethink our systems, our preparation, and our vigilance to counter this risk. Okay, so we know the territory. And we definitely know the stakes. Let's really drill down into the specific challenges we're up against. And these aren't just little day-to-day annoyances. These are systemic problems that have a direct impact on patient safety. You know, you can really group all the headaches we face into 3 main buckets. First, there's the physical environment itself. The rooms, the lack of equipment, just being so far away from everything. Second, you've got the money side of things, payment systems that just don't support the kind of care we need to provide. And third, and this one is huge, you've got the operational and cultural barriers that can make simple communication and teamwork feel impossible. Let me paint a picture, and I'm sure every single one of you has been in this exact room. The C-arm is set up perfectly for the proceduralist, but for you, it's a wall, completely blocking your access to the airway. Your monitors are somewhere behind you, the suction is on the wrong side of the room, and if you need help, it's a 5-minute sprint down the hall. These spaces aren't just inconvenient. They can be fundamentally unsafe without us making major changes on the fly. And beyond the physical walls, there's this massive cultural wall. Think about it. In the OR, we have a shorthand with surgeons. We've worked together for years. They get what we need. But in a NORA suite, we're often working with a proceduralist who is used to doing cases alone, maybe with a little bit of sedation from a nurse. They might not get why we need a timeout or why a shared airway is so dangerous. It means we have to be 10 times more proactive and clear in our communication. Okay, this table is pure gold. This is our playbook for fighting back against the operational chaos. For every single problem, bad room design, messy schedules, no pre-op process, there is a solution, and that solution needs to be led by us. The message here couldn't be clearer. We have to stop just reacting to bad systems and start designing better ones. And let's be real, fixing these problems isn't just about getting a new anesthesia machine or hiring more people. It's about building a culture of safety from the ground up. And that culture rests on these 5 pillars: constantly learning, holding each other accountable in a fair way, real teamwork, using data to get better, and making sure information flows freely. This is the foundation. Without it, nothing else matters. All right, let's get into the nitty-gritty. We're going to parachute into some of the most common neuro battlegrounds, starting with the high-volume, high-risk worlds of the endosuite and interventional radiology. This is where the rubber really meets the road. So here's our field guide for a place like the advanced endoscopy suite. You get a procedure like an ERCP or a POEM, and you're immediately in that classic NORA trap. The patient is prone, so good luck getting to the airway. That airway is being shared with the endoscopist, so aspiration risk is through the roof. That's why a tube is often your best friend here. Then you've got the massive CO2 insufflation causing hypercarbia, sub-Q air, even a tension pneumo. The only way to win is to be hypervigilant with your capnography, control the ventilation, and never stop talking to the team. Now we head over to interventional pulmonology, and it's a totally different game. Here, the patient's own lungs are the primary challenge. They have almost no respiratory reserve. The second a rigid scope goes in, their ventilation is shot, which is why TIVA is pretty much the only way to go. Your success in this room is determined before the case even starts, with a thorough pre-op and a bulletproof, ready-to-go airway plan. Now let's step into the world of image-guided procedures. Doesn't matter if it's IR, CT, or MRI. You're going to face the same set of challenges every single time. First, the gear itself creates a wall between you and your patient. Second, radiation is a personal health hazard for us. Third, you've got contrast eye, with risks of allergies and kidney injury. And finally, remember, these are all poke-through-the-skin procedures, which means a patient can be bleeding out internally, and the only sign will be on your monitor.
When we talk about radiation, there is only one rule that matters: ALRA, as low as reasonably achievable. And I want to be crystal clear, this is about protecting ourselves. There's data showing that because we have to be at the head of the bed, our radiation exposure can be 3 times higher than the interventionalist doing the procedure. We absolutely have to take this seriously.
So how do we put ALRA into practice? It's actually pretty simple. Just remember 3 things: time, distance, and shielding. Spend as little time in the beam as possible. Take 2 steps back whenever they're on fluoro. That distance makes a massive difference because of the inverse square law. And wear all your gear: lead, thyroid shield, glasses, everything. These are not optional. Okay, now for what might be the single most hostile place we have to work: the MRI suite. That giant magnet turns any normal piece of metal into a deadly projectile. And once the patient is inside that tube, they're gone. You can't get to them. So everything has to change. You need special MRI-safe machines, pumps, monitors. Your EKG is useless, so your pulse ox and A-line become your lifeline. The only strategy that works here is absolute obsessive vigilance. Triple check for metal, use super long tubing, and stay glued to those monitors from the control room. All right, take a deep breath. We're now heading into the NORA boss level, the neurointerventional and cardiac cath labs. The procedures here are unbelievably complex, and the physiological swings are just off the charts. Aneurysm coiling in the neurointerventional suite. This is like a masterclass in blood pressure management. Your job is to keep the patient perfectly still and then wake them up fast for a neuro exam. But the real trick is this. 1 second, the aneurysm ruptures, and you need to drop the pressure to almost nothing right now. The next second, there's a clot, and you need to crank the pressure up to perfuse the brain. You are on a razor's edge. An A-line is non-negotiable, and you have to be in lockstep communication with the neuroradiologist. When it comes to an acute stroke, there's only one thing that matters. Time is brain. Our entire job is to help them get that clot out as fast as humanly possible. And this leads to the great debate in stroke anesthesia: GA or MAC. General gives you a perfectly still patient, but it can cause hypotension and takes more time. MAC is faster, but you risk the patient moving at the worst possible moment. There's no easy answer here. It's a judgment call every single time. All right, let's shift from the brain to the heart and talk about the EP lab. Our role in here has just exploded, mainly because things like atrial fibrillation ablations have become so common. And these aren't quick in and out procedures. We're talking 4, 5, even 6 hours. That requires deep sedation or a full-on general anesthetic to get the absolute stillness they need to map the heart's electricity. What's so wild about these ablation cases is that you have to unlearn some of your basic instincts. Your goal is stillness, but you have to use anesthetic agents that don't suppress the very arrhythmia they're trying to find and burn. Sometimes, you even avoid using muscle relaxants because the electrophysiologist needs to see if they're stimulating the phrenic nerve. It's a completely different way of thinking about anesthesia.
And then you have structural heart cases like TAVR. Here, our role has completely evolved. We're not just providing anesthesia anymore. We're co-proceduralists. Our hands on the TEE probe are guiding the valve into place. And we have to manage these insane but intentional moments of hemodynamic collapse, like when they rapid pace the ventricle to deploy the valve, which is basically a controlled 10-second cardiac arrest. The risks are huge, and our role is absolutely central to success.
Whew. Okay, so after that whirlwind tour through the NORA world, what's the big takeaway? Where do we go from here? The final piece of this is about the future, because it's not enough to just survive these cases. We have to position ourselves to lead. To really succeed in NORA, we have to make a strategic shift. We have to stop being seen as just a service provider and become a true, indispensable partner. That means we use data to prove how we make things safer and more efficient. We take the lead on fixing broken schedules and triage systems. We work with everyone to build better financial models. The end goal is to be seen as the innovators who make all of this advanced care possible and safe. You know, this quote just says it all, doesn't it? Everything that makes us successful in the operating room, our vigilance, our teamwork, our communication, those are the exact things we have to bottle up and take with us to every corner of the hospital. These are not soft skills. In the NORA world, they are survival skills. And so I'll just leave you with this one final thought. This massive expansion of NORA, it's not a threat to our specialty. It's the single greatest opportunity we have. It's a challenge for us to innovate, to adapt, and to prove our value in a whole new way. The real question isn't whether NORA is here to stay. It's how each and every one of us is going to step up, not just to work in this new frontier, but to lead.